To the deep dive. Today we're tackling a really vital topic for those of you in medical and paramedical studies. Cognition enhancers. You might know them as nootropics.
That's right.
Think of this as, a focused session. We want to help you build your understanding of these meds used for various brain conditions. We've got some excerpts here from a cognition enhancer overview. And our mission, really, is to pull out the essential info, what they're used for, how they work biologically, and the key clinical points you'll need as future healthcare professionals.
Exactly. We want to give you a clear, practical breakdown of these medications and sort of where they fit in clinical practice.
Okay, great. Let's jump right in then. Our overview mentions several key areas where these enhancers pop up. First, there's Alzheimer's disease, big one. Medications like Dunpezil, rivastigmine, memantine are used there.
Right. The mainstays for Alzheimer's.
Then ADHD. Drugs like modafinil and methylphenidate might be used, but it's off-label. Important distinction.
Yes, not their primary approved use.
Age-related cognitive decline is another. Paracetam gets a mention, though we should stress it's not FDA approved here in the U.S.
Right.
Used elsewhere, though.
That's a key point about pyracetam, yeah. Availability and approval varies.
We also see them for narcolepsy and shift work disorder, modafinil again. And finally, mild cognitive impairment, or MCI. Here, things like omega-3s, vitamin E supplements are sometimes considered.
Although the evidence for supplements in MCI is, let's say, quite variable. It's not as robust as for the pharmaceuticals in Alzheimer's, for example.
Good point. So a real mix of applications and definitely different levels of evidence we need to be aware of.
Absolutely crucial. Just because they're all called cognition enhancers doesn't mean they're equally effective or well proven for every condition.
Right. Now, to really get a handle on these clinically, we need to look at the classifications and how they actually work, the mechanisms. Our overview gives us 5 main categories.
Okay.
First up, cholinesterase inhibitors. Think Dunpezil, maybe you've seen Donep, or rivastigmine, like Revam.
Common ones, yes.
Second, NMDA antagonists. Memantine here, brands like Mentadem or Abixa. Third, stimulants. Modafinil, like Modalert, and methylphenidate, maybe in Spiral.
Used for wakefulness mainly, but sometimes off-label for cognition.
Fourth, AMPA modulators. Piracetam is the example, Nootropic, or Cdem perhaps.
The one with the less clear mechanism we mentioned.
Exactly. And finally, number 5 is supplements. Your omega-3s, fish oil, ginkgo biloba, like ginkgoba.
Right. Recognizing these different classes is really fundamental. They all target the brain, but through pretty different pathways.
Okay, let's dig into those pathways. Starting with the cholinesterase inhibitors Dunpezil, rivastigmine. How do they actually improve cognition?
Okay, so this mechanism is fairly well understood. These drugs work by blocking an enzyme, acetylcholinesterase.
Right.
And this enzyme normally breaks down acetylcholine. Acetylcholine is a key neurotransmitter for memory and attention.
So you block the breakdown enzyme?
Exactly. You inhibit acetylcholinesterase, so you get more acetylcholine hanging around in the synapse. This boosts cholinergic signaling, which can improve cognitive functions, especially memory. And as the overview notes, they're first line for mild to moderate Alzheimer's.
So we're not fixing the Alzheimer's itself, but kind of maximizing the brain's remaining ability to use acetylcholine for memory tasks.
That's a good way to put it. Symptomatic improvement by enhancing existing function.
Okay, that makes sense. Now, what about the NMDA antagonists? Memantine, how's that different?
Memantine uses a different approach. It's a non-competitive antagonist at the NMDA receptor.
NMDA receptor involved in learning, right?
Yes, learning and memory. But if these receptors get too much stimulation from the neurotransmitter glutamate, it can cause damage. It's called excitotoxicity. Think of it like overloading a circuit.
Ah, okay.
So memantine dials down that excessive stimulation without completely blocking the normal necessary activity of the receptor. It protects against that excitotoxicity.
And where does it fit in treatment?
It's primarily for moderate to severe Alzheimer's. And here's a key point, maybe an exam tip from the source. It's often used with Dunpezil.
Ah, combination therapy.
Right. You're targeting 2 different problems: boosting acetylcholine with Dunpezil and reducing glutamate toxicity with memantine. It suggests you need a multi-pronged approach, especially in later stages.
Interesting. So boosting one system, protecting another from overactivity makes logical sense. Okay, let's switch gears. Stimulants like modafinil, used for narcolepsy, sometimes off-label for ADHD focus. How does it work?
Modafinil's mechanism isn't perfectly crystal clear, but we have a good idea. It seems to weakly inhibit dopamine reuptake.
Okay, so more dopamine available.
A bit more, yes. And dopamine is important for alertness, focus, motivation. Plus, it also seems to activate other wakefulness pathways involving orexin and histamine.
Orexin, involved in sleep-wake cycles.
Exactly, so it promotes wakefulness through multiple routes. And importantly, the source highlights its lower abuse potential compared to some other stimulants.
That's a big plus, clinically.
Definitely. Makes it a preferred choice for things like narcolepsy, where long-term use might be needed.
Agreed. Lower risk is key. Okay, moving to AMPA modulators, piracetam. You mentioned the mechanism is less clear.
That's right, it's not as well defined. It's thought to modulate AMPA receptors, another glutamate receptor type involved in synaptic plasticity, basically how brain connections change with learning.
Okay.
It might also affect neuronal membrane fluidity, potentially making brain processes a bit more flexible, like switching between tasks.
Yeah.
But again, need to stress, not FDA approved, and the evidence for how well it works is limited. It is used in some places for age-related decline, like the overview said.
So, still a bit of a question mark around its exact function and effectiveness.
Yeah.
And briefly, the supplements omega-3s ginkgo for MCI.
Yeah, mentioned in the overview, but the evidence base is still developing, quite varied. We're focusing more on the pharma agents today with clearer mechanisms, but good to know they're out there.
Definitely. So, summing up the why cognition improves, it's mainly boosting acetylcholine, like with donepezil, or reducing glutamate's potential damage, like with memantine.
Those are the primary well-established mechanisms we're targeting with the main drugs, yes.
And the overview also brings up resistance, right? Like, the drugs might become less effective over time in Alzheimer's as the disease progresses, and tolerance with stimulants.
That's a really vital clinical point. These meds often manage symptoms, improve quality of life for a time, but they don't stop the underlying disease like Alzheimer's progressing. And yeah, with stimulants, the body can adapt, meaning you might need dose changes down the line. They aren't always permanent fixes.
Okay, good reality check. Let's shift now to how the body handles these drugs. Pharmacokinetics, onset, metabolism, excretion. Our overview has details. Let's start with donepezil.
Okay, donepezil. Orally, you're looking at an onset of maybe 3 to 4 weeks before you see clinical effects. Metabolism is mainly liver, using those cytochrome P450 enzymes, specifically CYP2T6 and 3A4.
Common metabolic pathways.
Very common. About half of it then gets excreted via the kidneys.
Got it. And memantine.
Memantine takes a little longer for onset, maybe 3 to 6 weeks. Interestingly, very little liver metabolism. It's mostly excreted unchanged by the kidneys, about 90%.
So kidney function is really critical for memantine then.
Absolutely critical. Big consideration.
Okay, what about modafinil, the stimulant?
Much faster onset for modafinil, usually 1 to 2 hours after you take it orally. Metabolism is liver, again, mainly CYP3A4. And most of it, around 80%, goes out through the kidneys.
And lastly, piracetam.
Piracetam's also pretty quick, maybe 30 to 60 minutes onset orally. What's interesting here is basically no significant liver metabolism. It's almost entirely excreted unchanged by the kidneys.
Okay, another one where kidney function is key. That pharmacokinetic profile is definitely essential for dosing and thinking about interactions. Let's move to some practical tips, the clinical pearls from the overview.
Yes, these are good takeaways for practice. For donepezil, it's usually once daily dosing, typically 5 or 10 milligrams. The absolute key pearl, titrate slowly, start low, go slow.
Why slow?
Helps minimize those potential GI side effects like nausea, much better tolerated if you ease into the dose.
Right, and for memantine, what's the pearl there?
Same theme, really.
Like-
Careful titration is crucial, mainly to reduce the risk of dizziness. The standard approaches start at 5 milligrams a day, then increase by 5 milligrams each week until you reach that target dose, usually 20 milligrams a day, often split into 10 milligrams twice a day. Again, slow and steady wins the race for tolerability.
That slow titration seems like a really important theme, especially thinking about older patients who might be more sensitive. Speaking of side effects, let's talk adverse effects.
Yeah.
The overview groups them by system, which is helpful.
Yeah, it is. Starting with GI effects, nausea, diarrhea, very common with donepezil.
And why is that?
It's likely due to that increased acetylcholine stimulating gut motility management. Taking it with food can help, and again, that slow dose titration is key.
Makes sense. Acetylcholine affects the gut. What about CNS effects? Central nervous system?
Dizziness is pretty notable with memantine, probably related to how it fiddles with glutamate receptors.
Okay.
Headache is common with modafinil, maybe linked to its dopamine effects. For both, if they're troublesome, reducing the dose might be needed.
And cardiovascular? Any heart concerns?
Yes, bradycardia, a slow heart rate, can happen with Dunpezil.
What?
Again, it's the increased acetylcholine. It can increase vagal tone, which slows the heart. So you definitely need to monitor heart rate for patients on Dunpezil and be very cautious or avoid it if someone has existing heart block or severe bradycardia.
So checking pulse becomes pretty standard monitoring for these patients.
Absolutely, especially those with any cardiac history.
Okay. Lastly, psychiatric side effects.
Insomnia can be an issue with modafinil. Makes sense, it's a wakefulness promoter, partly via dopamine. The standard advice is to take it early in the day, usually the morning, to try and avoid sleep disruption.
So really understanding why these side effects happen helps you manage them better.
Good.
Now, what about when you shouldn't use these drugs? Contraindications.
Right. The overview gives us absolute ones, definite no-goes, and relative ones used with caution. For Dunpezil, an absolute contraindication is severe asthma or COPD.
Because of the acetylcholine effect.
Exactly. It can increase bronchial secretions, which could be really dangerous in someone with severe respiratory disease. For memantine, severe renal impairment creatinine clearance, less than 5 millibars per minute, is absolute, because it's almost entirely cleared by the kidneys.
Okay, those are clear stops. What about the relative ones, the be careful situations?
Modafinil needs caution if someone has uncontrolled high blood pressure or arrhythmias because it can raise blood pressure and heart rate.
Makes sense for a stimulant.
And for piracetam, renal impairment is relative. You don't necessarily have to stop it, but you likely need to adjust the dose down, again, because it relies on kidney excretion.
So it really highlights you need a good patient history and workup before starting these.
Absolutely. Assess their conditions thoroughly first. Safety first.
Okay. What about interactions with other drugs? Always a big concern.
Huge consideration. One key interaction: Dunpezil plus anticholinergic drugs.
Like medications for overactive bladder or some older antidepressants.
Yes, things like that. Since Dunpezil increases acetylcholine and anticholinergics block acetylcholine, they basically work against each other. The anticholinergic can cancel out the benefit of the Dunpezil.
Okay, direct opposition. Makes sense. Any others from the overview?
Using memantine with amantadine needs caution. Amantadine is also an NMDA antagonist, used sometimes for Parkinson's or flu. Using both together increases the risk of CNS side effects because you're hitting that same receptor system twice as hard, essentially.
Additive effect, got it.
And finally, modafinil. It can interact with drugs metabolized by that CYP3A4 liver enzyme. Importantly, it can make oral contraceptives less effective.
Well, that's critical to counsel patients about.
Absolutely. And it can also decrease the effect of warfarin, the blood thinner. So careful monitoring is needed there too.
Wow, okay. So always need that full medication review, including over-the-counters and supplements, right?
Crucial step.
Let's circle back quickly to dosage specifics and maybe reinforce those clinical pearls.
Sure. Dunpezil, typically start 5 milligrams once daily, can go up to 10 milligrams once daily after 4 to 6 weeks based on response and tolerance.
Okay.
Memantine. Start 5 milligrams once daily, increase by 5 milligrams weekly. Target is usually 20 milligrams per day, often given as 10 milligrams twice a day for better tolerability.
Right, that slow titration again.
Modafinil. Typical dose is 100 to 200 milligrams orally per day, usually just in the morning. Max dose recommended is 400 milligrams per day.
And the overview had that specific geriatric note. For older adults.
Yes, very important. For older patients, definitely start low with both memantine and Dunpezil. Lower initial doses. It helps minimize risks like dizziness and falls, which are major concerns in this population.
Good reminder that start low, go slow is extra important in the elderly. What if things go wrong? Overdose, toxicity, and management.
Right. If you have a cholinergic crisis from too much Dunpezil, for instance, you'll see signs like excessive drooling, muscle weakness, maybe seizures, and a very slow heart rate bradycardia.
Scary stuff. What do you do?
Immediate action is atropine. That's the antidote. Typically 1 to 2 milligrams IV. Plus, obviously, full supportive care, airways, breathing, circulation.
Atropine for cholinergic crisis. Got it. What about modafinil overdose?
Signs that are usually more like agitation, maybe bad insomnia, fast heart rate tachycardia. Management is mostly supportive care. If the agitation is severe, benzodiazepines like lorazepam can be used to calm the patient down.
Okay, so recognizing the specific signs for each type of overdose and knowing the immediate steps, like atropine for cholinergic crisis, is key. Finally, let's hit those critical warnings and keynotes from the overview. Black box warnings, things you absolutely must remember.
Definitely. For modafinil, you have to know about the risk, although rare, of severe skin reactions. Stevens-Johnson syndrome, TAN.
Serious stuff.
Very serious. Patients need to know to report any new rash immediately. Also, potential psychiatric effects with modafinil anxiety, mania, even hallucinations. Need to monitor for those.
Okay. Anything else critical?
About Pyristem.
Okay.
Just keep repeating, it's not FDA approved in the US, and the evidence for its effectiveness is limited. Manage expectations.
Right.
And a high-yield fact, good for exams. Memantine is the only drug currently approved specifically for moderate to severe Alzheimer's disease.
Those are all really crucial takeaways, especially the modafinil warnings and the status of pyricetam.
Okay, as we wrap up, the overview gives us a kind of final exam checklist, the absolute must-knows. Let's recap those quickly.
Good idea. First, MOA mechanism of action. Know the difference. Cholinesterase inhibitors boost acetylcholine. Memantine blocks excessive NMDA activity.
Okay.
Second, monitoring. Key things. Heart rate with Donepezil, kidney function with Memantine, watch for psychiatric symptoms with modafinil. Got it.
Third, contraindications. Remember, severe COPD for Donepezil, severe renal failure for Memantine, absolute no-goes.
Right.
Fourth, drug interactions, big one. Anticholinergics fighting against Donepezil. And fifth, toxicity management. Know that atropine is your antidote for a cholinergic crisis.
Fantastic. That's a super concise summary of the core information.